All right, let's talk about cellulitis and abscesses. So, differential diagnosis for cellulitis, toxic shock syndrome, necrotizing fasciitis, atopic dermatitis, septic arthritis, HSV, osteo, drug reactions, vasculitis, insect bite, and a vaccine site reaction. So probably the things we see the most would be a drug reaction, osteo, septic arthritis, and maybe an allergic reaction. So predisposing conditions, so any trauma to the skin, whether you can see it or not, can cause cellulitis. Eczema, which would fall under that category. Patients who are obese, immune suppressed, or have pre-existing infections such as tinea pedis or athlete's foot and impetigo. So as far as what goes on from a pathology standpoint, the most common cause is beta hemolytic strep, or for example, group A strep. Other common causes, especially within our hospital, we see strep pyogenes and then Staph aureus, specifically MRSA. Cellulitis with abscess, typically we see staph and MRSA in that case as well. And so what happens is you get these little micro breaks in the skin, the bacteria goes in and then causes the inflammation and the infection. So the clinical manifestations are pretty easy to pick up. So you'll see the skin being erythematous, warm to the touch, edematous or indurated, if not both. You may feel fluctuance if there's an abscess present. Sometimes you can see other findings such as lymphadenitis or lymphangitis as well. And then you can see lymph node enlargement without the inflammation aspect. As far as evaluating cellulitis, it's typically done by exam. If you're going to get any study, it would be an ultrasound, and that would be if you're concerned for an abscess. If the patient's toxic appearing, you may get a blood culture and then a CBC as well, and possibly a CRP to monitor resolution of the infection. But otherwise, we're not going to do much. Treatment, the main thing we are concerned about is MRSA. So typically we use clindamycin or Bactrim. An issue in pediatrics with Bactrim, though, is that it can cause Stevens-Johnson syndrome. So typically you'll see us do clindamycin alone. And then you can try Keflex if you're not worried about MRSA. And that concludes our talk.